Okay. Hi, everybody, and welcome to our webinar on veterinary cryosurgery. Dr. Mosby and myself will be your instructors, presenters. A few rules as we go forward into the lecture. Now, you may be live with us today, or you may be watching this sometime in the future. There's during the live portion today, you can send in your questions. Just send those in as part of the chat. Or later on, if you watch this kind of remotely after the fact, feel free to use the email at the end slide to send in your questions, and we'll be sure to get you answers. Now, the reason for this today is because we've had certain products in the market, and we've been talking about cryosurgery for a number of years, specifically veterinary cryosurgery. And so over the course of time, people in the field, other clinicians, they've come up with some common questions and themes. And so we want to answer those today. So we kind of update you on what you should be thinking about when you use cryosurgery, how best to do this. And so we'll run through some basic slides, which are sort of, let's review the facts. And then Dr. Mosby, Tim, will be reviewing some of the logic and clinical practice as he uses cryosurgery. And then we'll talk about, we always like to bring up something new we're hearing from the field. And so today we'll be sharing one of those indications and a little bit about the protocol and how best to do this. So with that said, let's move forward then and begin to look, at our slides. So we're gonna just one slide on the basics of cryosurgery. These are not necessarily the order in which everything will be done, but we always want to review, is cryo the right choice for addressing a particular topical benign lesion versus other techniques? What are the common indications and some of the new ones that we're seeing? And then lastly, learning and techniques. So this is just some common issues that we've heard coming up through kind of customer service and those who are in the field working with you as clinicians, as well as techniques that may be helpful to you going forward. So how to optimize vet cryosurgery. This is, just boiling down. There's a lot of slides that we sometimes present during a race credit course that is taught by Tim and I. But the basics boil down to a couple simple things. One, you've got to be really aggressive when you use cryosurgery to treat a lesion. Based on the physiology of canine and feline skin in particular, they can take it. You can be aggressive far more than you can with, say, human skin for with the same applications, because they will not blister. You do not create an open wound, and quite frankly, it is the best way to get a good outcome. To achieve an aggressive freeze, there's two components. One is obviously the temperature, the second is time, and then the third that comes into that is how many times I perform the freeze and then a thaw. And so multiple freeze thaws are almost always required unless it's really small or it's in, say, an eyelid. You're going to want to think in terms of 2 to 4 cycles that are done when you are treating a topical lesion. And as we'll look at in a moment, there's a couple different ways to apply cryogen gas. You could spray it, you can use a bud, or you can use a cone. If you're spraying, then the third point we want to make, because this comes up from time to time, is you need to be close to the lesion to apply. And that means within the width of a nickel, or in talking to some of the folks we have in the field, they'll say go very close to the surface, begin your spray, and then back away just a little bit. And that's about the right distance. From an art perspective, that's the one part of this in using a spray that you have to keep in mind. Okay, so let's now talk about this particular short session and what we want to accomplish. So versus when we teach on cryosurgery at a race course level in our more general, where we cover some of the principles, but a lot of different technologies, today we're really talking about two, and that's on the left, the CryoMega dual delivery, and over on the right, the CryoLab Vet. The CryoMega dual delivery applies cryogen in one of two ways. You can see the picture here of the cone, in which cryogen gas is dispensed, and then it's allowed to bubble on the surface of the skin, drawing heat and freezing it, or on the right, where you're spraying nitrous oxide directly onto a lesion and doing that multiple times, as we had discussed in the slide just a moment ago. Both of these are the primary technologies we're assuming you're using, and by logging into this, we want to teach you more about these in particular, or any issues that we've seen coming up in the field. Now, for both, they each have their pluses and minuses. For those who have the CryoLab Vet, you know that this is the large capacity, coldest temperature that you can get into a practice. For the CryoMega Dual Delivery, this is where the unique design of those cones that you see, as well as the applicators, give you this flexible kit that can be used in a lot of different ways. It requires, though, for you to do some of the steps more manually. Now, when we look at both of these technologies, the list of indications really is about the same. However, warts are still top of the stack, eyelid tumors, gland tumors, skin tags. What's really started to rise up, and this is an older set of data for us, is last year we introduced the idea of using cryosurgery for lick granulomas. And this is an alternative to a pharmacological approach or some other herbal medicine, as an example, to dissuade licking there. And the idea is that cryosurgery numbs the area, and so the patient stops going after it because they don't sense it anymore, and it gives a chance for then a healing process to take place. That's been really successful, and we're starting to see that noted more and more as kind of a go-to in terms of cryosurgery and being able to go after difficult cases. So there are learnings we get during the year, and that's partly what we'll communicate today, specifically about sebaceous glands in just a few moments. Now, before that, what we wanted to do was actually go to Dr. Mosby. And here, let's just engage a little bit in some of the questions that come up as a clinician so that you guys can hear it, because you're the ones stepping out of clinic to listen to this webinar and maybe give you some things that you can work with. So work with us here. Let's just go through some of the questions. So Tim, I'm going to put you, up front and center here to answer some of these. So if I was asking you some of these questions, let's let you run through your answers. But when do you use the CryoLab and cryosurgery? And then what indications in your clinical experience do you focus on, and which patients do you use it with?
I mean, sebaceous adenomos, skin tags are probably still #1 thing we treat, just because so many come in with them, and they're pretty quick, easy treatments. So definitely, you have a patient who has one or a few smaller lesions, those definitely I tend to use cryosurgery on. If you're talking a bunch of lesions or bigger lesions, we might err more on surgery depending on what the patient or the owner wants. Patients range from anything. I mean, certainly even with papillomas, that works well on. A lot of them are the older, small, white, fluffy dog with a bad heart murmur that nobody wants to put under anesthesia. So those are still the main uses. Eyelid tumors, meibomian gland adenomas, for the right patient, the patient who's going to sit and tolerate the treatment to be able to freeze it well, I think it works well. And lick granulomas, especially if you can get them early on when they're smaller, or if you've managed to treat it and get it reduced in size, and certainly use it for those too. Those are the main things we use them for.
So in your practice, is there a limitation in size, and at which you kind of look and go, that's too big for me, I'm going to go on and do something else?
It does depend a bit on the lesion, and I'd say size-wise, it's probably more depth of the lesion than diameter width of the lesion. Certainly, we know you can't freeze much deeper than a centimeter. So any sort of lesion that's pretty deep, now I usually say, all right, we're either going to have to do this multiple times to take care of it. But no, I mean, otherwise, kind of just external diameter width of it. Probably get up to 3-4 centimeters. At least it's the talk that, hey, we can treat this, but it's probably going to take 2 or 3 treatments for something that big. I'd say those are probably the main limitations. And then every once in a while, if you have a patient who just doesn't tolerate it well, you have it in a very sensitive location. I've definitely found down on like the carpus area, where there's not a lot of cutting over the bones, they might be a little more sensitive. Those we still do it, but we'll talk more about using local anesthesia sometimes or some mild sedation if they want to do it.
Well, actually, you touched on something else, and I was going to ask the question because it comes up all the time.
Yep.
Do I need local anesthesia or general anesthesia or any anesthesia? How would you answer that?
General anesthesia, almost never. I'd say very rarely if you have a patient who just, is very anxious, nervous in the office and won't sit still. It's not usually, I don't usually find it's a pain thing. I usually find the patients that are hardest are the ones who just don't want to sit still anyway in the office for whatever you were going to do. So those may use some either just oral pre-medications like trazodone or gabapentin, or rarely we will do some injectable sedations like carbamazepine, sometimes Dextone, depending on the patient. But no, generally no. And I'd say only I'm finding sometimes with some patients who might be more sensitive or a lesion that's in a more sensitive location. Those I've started to use local more. So I'd rather have it done right the first time than mess around, try and treat it, and have to come back and do it again.
Mm-hmm. And so last question associated with this is, are there any limitations in terms of age or your preference in terms of age of patient when you use cryosurgery?
No, I really say age really has nothing to do with it. It's more comorbidities, and that's why sometimes we go towards this. You have valve disease, you have bad kidney disease, and we just don't want to go through anesthesia with any extra risks, or the owner just doesn't want to. So we end up doing it more frequently, I think, on older patients. But no, I mean, I certainly have done, puppies with papillomas and young dogs with histiocytomas up to, old dogs with big, ugly infected sebaceous adenomas. So no, I'd say there's really no limitation there.
Perfect. Okay, so hopefully that's helpful, and this format is helping some of the clinicians who will be watching this. So in your use of cryosurgery, how many freeze-thaw cycles do you typically do, and are there any limitations to how many you might do?
I do at least two. I'd say even the smallest lesions, I like to do two if we can get two good freezes. I'd say most lesions, especially things that are, around a centimeter or so, or larger, I like to get at least three. And every once in a while, we'll do four. But I find most of the lesions, I feel like 3, 4 is the limit. You're not going to get extra, I think, past that. If it's a bigger lesion, I think it's better to do your 3, 4. You're hopefully going to, reduce its size by at least 50%, sometimes 90%, and have them come back in a couple weeks and repeat it if it's one that one treatment's not going to totally resolve.
Yeah, and we'll talk about success rates next. That's actually a perfect segue to that next question. So part of it is what you tell the pet owner overall, but what's your expectation in terms of success rate? Because this comes up, where a clinician is asking us, going, well, not all of it came off, or only part of it came off, or how many times should I anticipate they have to come back? I mean, if you were the clinician and you said, Tim, how do I get this done in one treatment? Is there a way to do that?
Yeah, I think overall success rate is going to depend on what we're treating. Certainly things like sebaceous adenomas, skin tags, and a lot of this is size dependent. So anything a centimeter or under, I really expect 80 to 90% success on those first time, assuming the patient is tolerating it, which is generally very well is tolerated. But as long as you can get 3 good freeze-thaw cycles on those, no, I expect you're going to get a 90% success rate. Mm-hmm. Something like lick granulomas, which nothing works anywhere near 100% on lick granulomas. Yeah, lick granulomas, hey, 50-60%. I'm pretty happy if we at least get improvement with that, and I expect most of those, depending on how well we're treating the other factors that might have led to it. I usually expect people, hey, we're probably going to come back and treat this at least one more time. Larger things, if you're treating things 2, 3, 4 centimeters, no, then I think, especially depth-wise, if we know it's over a centimeter in depth, you're in all likelihood not getting that the first time. That's going to be a definite, hey, come back and let's treat what remains afterwards.
Right. So again, your point is well taken, and I think clinicians should be realistic then about expectations, but no, the more aggressive they are, the more likely they're going to take down whatever that lesion is to the margin with greater success.
No, definitely. Like I said, if you can get 30, let's say 3 30-second freeze cycles on almost anything, if you're getting it fully frozen for its size, you're probably going to have 90% success on those first time treatments.
Excellent. Okay, thank you. So a question that also has come in a number of times: are there any contraindications worth noting to the clinicians watching?
Yeah, I think the only one that we've ever really talked about being a worry was mast cell tumors. And I think this is still theoretical. I don't think I haven't had one where I say that know that I've frozen any, but I haven't had anything that we froze that, degranulated and caused a big reaction. I think that's probably our only contraindication is if you think there's a possibility it could be a mast cell tumor, all right, aspirate and try and rule that out. I mean, most of our things we're freezing, meibomian glands and sebaceous adenomas, I mean, those have very characteristic looks that mast cell tumors almost never look like. That would be the one contraindication that I feel like, all right, we know mast cells can degranulate. If we're going through this freeze thaw cycle, could we have like an anaphylactic reaction from massive degranulation? And, I think it's a theoretical thing. And it's one of those, hey, if you still had a patient, especially one of these, like a pug that tends to make low-grade mast cell tumors, I still would probably freeze it. I'd probably talk about, all right, we maybe retreat with an antihistamine and keep them on an antihistamine for a couple of weeks till we see them back. So that's still not a total contraindication. I think something we would just take more precautions for just in case.
So associated with this comes the question from time to time, should I be doing a biopsy and some histology before cryosurgery, or is it okay to start with cryosurgery and then go from there?
Yeah, I mean, the characteristic lesions we're usually talking about treating, I mean, I usually feel pretty safe going straight to cryosurgery. And I think even things, if you've had cutaneous melanoma, like, hey, treat it. It's one of those things, if it responds, not the way we expect, like, wow, that small lesion should have gone away totally. And 2 weeks later, it's like, hey, it went away. Now it's suddenly growing back. Hey, now you should definitely go take that thing off. No, I feel like unless your clinical suspicion is, hey, I think this is something that may not be benign or something we would be better off totally removing and biopsying. I think a lot of these lesions are kind of our nuisance lesions, and we know what they look like. We know we usually have a history on how long they've been there and how they've aged. So no, most of the things we do, I feel pretty good. Not doing histopathology. Like I said, some things I'm suspicious of, so things like histiocytomas. No, I aspirate those just to make sure it's not a mast cell tumor that's looking a little different than the average one.
Okay, great. So there's just two more questions here that we'll cover today. So what do you tell pet owners about home care after cryosurgery?
Leave it alone. That's a big one. Tell them. It's most of these things, even when they've been something, the dog has been chewing at, like an irritated skin tag. Like typically after we freeze them, it seems like it numbs it up. The dogs usually start leaving them alone. So I usually tell people to don't touch it. Keep an eye on it. We should, those first couple of days, you're probably going to see some redness to the area. I mean, we basically just gave it frostbite. So you'll see some changes there. And then 4 or 5 days, we like to start seeing some response, that you're getting some of the tissue necrosis, you're getting some black, scabby tissue. And usually I feel like it takes about 2 weeks to see if you're getting full resolution on lesion. So it's usually tell them leave it alone. If it's bothering them, let us know. Hey, if we need to use an NSAID, or we just need to use, a wrap or an e-collar, worst case scenario, to keep them away from it, we can do that. It's been really minimal, the number of patients I didn't have any issues afterwards. And of course, we're talking about something like a lip granuloma where we know self-trauma is a big thing. I will tell them, no, you need to put the cone on, put some covering on, keep the self-trauma from happening. But for now, everything else, it's usually leave it alone. Try not to touch it.
Okay. All right. Last question, as asked the clinician: are there any situations where you would not use cryosurgery?
I guess anything that is certainly of a larger size, that I think this might be quicker, easier to just go to surgery. Certainly we'll do that. Things where I'm suspicious maybe this isn't a totally benign lesion or something that's going to be recurrent, I might go to surgery before cryosurgery. And the mast cell tumor risk, those are probably the only 3 times. Besides things that it's stuff like, we're not going to treat subcutaneous lesions, things deep or intradermal, we're not going to treat those. No, that's probably the only thing, that or the patient who, the extra wiggly patient who's not going to tolerate us freezing around its eyelid and getting a good response. Those are the only times, I'll usually say don't use it. But even those patients, I think it's usually worth at least a shot before you give up on it.
No, well, no, that's perfect. And hopefully this gives some guidance and experience to some of the clinicians who may listen in on this. And so in the next few slides, we want to kind of wrap up with a few other ideas and updates. So the one thing I wanted to show, and I thought this was important as Tim and I discussed this lecture, is just established a little bit more of expectations and what to expect. So the one thing that has also fallen out, especially in the last years, cryosurgery use with these products is growing and growing, is when do you know it's working, and when do you know that maybe your technique needs improvement? And so the key is, after you do a treatment, within that first 48 hours, there should be swelling and redness that's evident. And then the transition to a scab, because there's going to be an exudate that forms that scab, and then it'll be usually 10 to 30 days later that the scab falls off. But the key is in the first day or so. If you don't see the redness and you don't see that little bit of swelling, then you likely did not do that initial treatment correctly, which means you froze for too short, or if you were using a spray, you were too far away. And this is the one training issue that we've had to work through with people. So we put it in the slide deck. It's now immortalized in the lecture, but we give you that as that one tidbit we want you to take away. Now, in the next slide, we want to talk about some learnings in the past year and little technique hints that have come up. And as Tim had mentioned, cysts are common, so we've come up with the simple phrase of freeze it, squeeze it, freeze it. And this is a clinical tidbit where when you see one of these infected cysts, the idea here is that you pre-freeze it, meaning I treat it once with either the spray or with a cone in this case. What that does is it firms up the material inside, which then you can squeeze after you've used, in the second image, a 16 gauge needle to puncture it, allowing it to come out. When you do that and you remove all that mass that's inside, basically then you come back in the last photo on the right, freezing it one more time. Now, in this case, we want to make note that that's a wound at that point, because what will happen is the membrane kind of collapses, and then you want to be cognizant that while the nerves may be dulled in that area or numbed because of the use of cryo, it's still, in this case, is an open wound. But this becomes a really successful way to treat these sebaceous cysts. So, and just adding this step of puncturing it rather than freezing it alone and squeezing out the contents is what makes all the difference. So like we've done in the last seminar, where we've talked about the hint of using cryo to treat lick granuloma, in this we'd like to give you the next hint, which is improved methods to treat sebaceous cysts. So Tim, I don't know if you want to comment on this at all.
No, I mean, I think we covered it. Because we get all of that non-vital material out of there, freeze it so you're actually killing the lining. I don't know, this one wasn't mine, but if it was this red and ugly, yeah, I'd probably say we have a wound, so I'd probably be sending it home with antibiotics and maybe some NSAIDs to decrease inflammation. I don't know if this one was bothered by it or not, but if they come in infected, I'd expect they're also treating that, the secondary infection with the cryo to kind of treat the primary cyst.
Mm-hmm. Yep. So our hint for today. Now, the last couple slides are real simple. I just want to talk about things that have come into us as in terms of some hints of things people can improve upon, and or explanations of the equipment itself that you may be using. So in this next slide, this is about the CryoLab Vet. And the CryoLab Vet, if you're not using it, if you're using the dual delivery, the CryoLab Vet is our basically instrumented delivery of cryogen gas using a spray. It kind of controls the whole process. And one of the things it does is it has a preset treatment time of 5 or 10 seconds. And on the wand of the cryolab, you press the button and it'll spray nitrous oxide for either 5 or 10 seconds. We do that in part because you don't want nitrous oxide in an uncontrolled manner just spraying continuously. The second is it ties into the idea that we said earlier, which is you need to do freeze-thaw cycles. So I think Tim mentioned earlier he was doing 3 times 30 seconds. So that might be 10, 10, 10 run, done, and then let it thaw, and then 10, 10, 10, let it thaw. That's a freeze-thaw cycle, or it could be 10 seconds, let it thaw, 10 seconds, let it thaw. Those are all possibilities, but what we don't want clinicians to believe is that I do it for 10 seconds and I'm done. That has come up a number of times. So we say it here to again reinforce what we've been saying in the field, which is multiple freeze-thaw cycles are expected. The cryolab vet has a preset time, so we control the dispense of the nitrous oxide and how many times it may be dispensed. And the ease of dispense, again, is just by pressing the button on the wand. So that's point number 1. For the dual delivery device, it's kind of the same thing. The dual delivery device works where, and I have one here because this is easy enough to do, you flip it upside down, there's a trigger on it that you pull, which dispenses the gas into the cone, and that's what's shown in the picture down below. We have a number of clinicians that pull the trigger correctly for the 3 to 5 seconds, but what you have to do after that is let the gas bubble underneath for up to 40 seconds it may take to fully evaporate. You don't want to lift it up after 3 to 5 seconds. That's not the actual treatment time. That's just to dispense the gas. Now, again, practice makes perfect. Everybody gets it eventually, but I just want to immortalize that, you know, as we go through this, because again, we're intending to speak on the things you've asked us about, make sure we communicate back some updates or hints or practice questions that have been coming. So with that, then we can start to wrap up and just let you know that we will continue to do training. We believe in it. We are learning more and more as we go. We thank you for using the products. We hope they're accomplishing what you want to accomplish with using this modality. Clearly, we will have more as time goes on, and we have a YouTube channel which is shown here, and we have videos for the cryolab vet operation and the dual delivery operation. So as we continue to move into the future, we hope to get to working on procedures and conditions that are helpful to you to treat with cryosurgery. We thank you again for your time. Tim, thank you for being on the call today and helping to teach other veterinarians how to use cryosurgery. So with that, we'll close, and again, send your questions to us whenever you would like. Thank you.
Thank you all.